My name is Khaled Nour. I'm a gastroenterologist. My main specialty deals with GI disorders and liver and pancreas. And today we'll talk about acid reflux disease. And you may know it's a very common disease that's affecting, I would say, maybe even 15 to 20% of the population of the country and maybe even in the world. So we're talking about maybe 30, 40 million people or even more having acid reflux. And we're talking about people who have 2 to 3 episodes per week of acid reflux. But if we include people who have acid reflux once every month or so on, we may be talking about even double that amount of people. So acid reflux in general, before we talk about acid reflux, let me just show you, this is a digestive tract, and I'm sure you're familiar with some of its details, but it starts with the mouth, and it's where we have the food masticated and then swallowed all the way into the esophagus, and it goes down into the stomach. And then maybe this would show it a bit better. In the stomach, the food is mixed with acids and some enzymes that help digest some of the food. And then it passes down into the duodenum, the beginning of the small intestine, and then the rest of the small intestine, almost 4 to 5 feet to small intestine. Here in the small intestine, a lot of enzymes come from the pancreas, and bile comes down from the gallbladder, mixes with the food, and helps digest the food. Most of the absorption of the nutrition usually, of the nutrients usually happens here in the intestine. And then finally, the residues at the very end come with water into the colon, and throughout the colon, water is reabsorbed back again so that you don't get dehydrated, and eventually solid stools with debris make it all the way down. So this is what happens usually. That's the flow of the food throughout the intestines. So what happens when you swallow? This is the most important part. We're going to focus on the upper GI tract here. When you swallow, usually the mechanism that allows food to be transferred from the back of the throat here into the upper part of the esophagus is very well coordinated. The muscles neurologically controlled. Some muscles contract, some muscles relax, and food is transferred back into the upper esophagus while protecting the airways so that we don't end up with liquid or food going down into your trachea or your airways. There are 2 important muscles in the esophagus, one at the upper part and one at the lower part. This is called the upper esophageal sphincter. It's not a valve or anything like this. I know some people think there's a valve there. It's just thickening of the muscle. This is a stronger, more concise and well-regulated muscle here. The same thing applies at the bottom of the esophagus here before it gets to the stomach. This muscle is thickened and it's well coordinated, and it's called a lower esophageal sphincter, or LES. When you swallow, this muscle opens, allows the food to go down, and then closes. Food makes it all the way down with the muscles contracting in one segment and then in another, all the way down to push the bolus all the way to the bottom here. Once it gets to the bottom here, this sphincter, this strong muscle, relaxes and allows the food to go into the stomach and then tightens back again. This should remain tight most of the time. And this is where the problem happens that allows reflux to happen at this sphincter. So the causes of the sphincter of the acid reflux, in some people, they would have only intermittent episodes of acid reflux. And these are the ones that I said maybe once a month or so on experience heartburn or acid reflux. And these are usually very transient, and any over-the-counter medication would take care of it and doesn't require further investigations by us most of the time. But we're focusing more on the chronic type of episodes here, the ones that keep repeating several times a week. And most of the problem usually happens at the area of the lower esophageal sphincter. The causes usually involves the sphincter relaxing, and the relaxation. And let me just mention here the relaxation of the sphincter, and I don't know if it's going to be. Yeah, I mean, the relaxation of the sphincter here is either transient, which means every now and then, without any reason, without the presence of food, it opens up. and then it closes back again, tightens again. Or it's permanent, which means that it's so weak it doesn't do its function. It doesn't really hold this area tight and prevent acid coming up. And in both situations, acid finds it easy to come up into the esophagus, and that's when you get the heartburn. The esophagus is different than the stomach. The stomach is prepared for the presence of acid. The lining is well protected. It produces the acid, so it can tolerate a significant amount of acidity. But the lining of the esophagus is quite sensitive for the acid. So when acid comes up, it irritates it, it causes inflammation, it gives us the burning that we complain of, or the heartburn. However, heartburn is not really the only symptom. The symptom of acid, most of us know heartburn, but they don't know the fact that acid reflux can give you other symptoms. It can give you chest pain. If this acid comes up and irritates it bad enough, you can feel chest pain. And sometimes it feels like even a heart type of a pain. And we have to send you to a cardiologist to make sure your heart is okay before we really check you for other reasons. It can also give you a problem swallowing. This coordinated movement of the food down the esophagus is lost once acid comes up. It irritates the muscle. Muscle doesn't work as well. And so food frequently gets stuck here. And you feel that it's not passing. I have to drink water to bring it down. And sometimes you have to even throw up the food to get relief. It can also give you cough, dry cough, goes all the way up and gets into the airways and irritate the airways, or hoarseness of voice. Some people who are used to singing end up losing this ability, and they feel that there is some hoarseness in their voice permanently or transiently. Also, it may give you a feeling of food coming back again, just like acid comes back again. And halitosis, so bad breath, can happen. Even bad teeth can be the result of or significant amount of acid reflux. There are people who complain also sore throat, the people who complain of a globus or a feeling of a lump sitting up there frequently in the esophagus. All of these are signs of acid reflux. If acid reflux gets bad enough, an ulcer starts developing, bleeding can happen, and a person can throw up blood. So vomiting blood can also be one of the signs. And if finally tumor or cancer develops in an area affected by the reflux over the years, weight loss and problem swallowing can happen as well. So among the common ones that we usually see are the problems with chest pain, soreness in the throat permanently, a problem with swallowing difficulty. These are usually the common ones. So who is at risk? Of course, I mean anybody at risk. It says obesity, but it doesn't mean that obesity or overweight is a reason for you to develop it, and everybody who's thin is not going to develop acid reflux. No, it develops in all weights, but it gets worse when you add weight. As a matter of fact, my patients usually come and tell me, and I ask them, you know, is there any change if the acid reflux was controlled with medication and now all of a sudden the medicine is not working well? I ask them, did you gain weight? And many of them say yes. And when I get them to lose 15 pounds, they come and say the weight has improved, weight loss has improved their heartburn significantly. So gaining weight can make your controlled reflux get out of control. The pregnant women know very well that later in the pregnancy, usually the pressure of a big pregnant uterus pushes on the stomach and causes a lot of reflux. Also, hormonal changes during pregnancy makes the muscle at the bottom of the esophagus relax significantly. And that's why they get a lot of reflux. Smokers get more acid reflux. People with asthma and any respiratory problems, and particularly people who have sleep apnea. So people who, during their sleep, snore and have an obstruction in their airways when they're sleeping, they end up gasping a lot during their sleep to get the air in. That suction, that negative effect usually sucks a lot of acid as well. So they always have a lot of acid reflux at night. So people with sleep apnea usually have reflux. There's one condition that happens mostly in diabetics, but we see it sometimes in other diabetics where the stomach doesn't work well. The nerves in diabetes are affected. So the nerves to the stomach help encourage the stomach to work, to empty itself. So a diabetic who's having problems with the nerves can also have the nerves to the stomach affected, and now the stomach is not really encouraged to work. It sits like a lazy bag and it collects the food and acid for a long time. They complain of nausea and vomiting, and they also have a lot of acid reflux. And usually trying medications and changing the medications doesn't help the reflux. Until we put them on a medicine that help encourage the stomach to work, then the acid reflux all of a sudden gets better. So this is an important condition in diabetics, and we test for that frequently as well. So is all the problem with reflux related to the symptoms of heartburn or chest pain, or is there something else that usually develops if you don't get it treated? In fact, the acid reflux is not as benign as we think it is. The complications, and we see the complications usually a lot, are many. One of them is, a common one is stricture. When you have an inflammation in the esophagus because of acid reflux, the inflammation heals with a scar, and the scar shrinks, and then another inflammation and another scar. And this continues on with the lumen opening of the esophagus getting smaller and smaller and smaller until it becomes as big as this pen, or even as big as the tip of the pen. And the patient usually, finds out half the way through that he's unable to swallow food. Food gets stuck. He manages at the beginning to go around the problem by eating soft food or by drinking liquids, and then down the line it gets worse, and now food doesn't get to pass, and then he has to throw it up. And eventually he eats, the food gets stuck, and he can't bring it up or down, and he comes to the emergency room, and commonly it's in the middle of the night for some reason, and we come in and take a look and take the food out and find that his esophagus is extremely narrowed. And I think I have a picture of this here, where you can see here that the opening of the esophagus, this is as how big the esophagus is, but it shrunk at the very bottom to this area. So this lumen is reduced to almost 1/5 to 1/6 of its size. And you can see why food wouldn't be able to go through this. And then we have to go through repeated episodes of dilating it or stretching it. We don't do it all at once. We take him through it step by step, so he comes in for repeated endoscopies to get that done. And scar is a very resistant type of a tissue. It comes back again. So even though we stretch and stretch, he feels better, but then a few months down the line, the scar reforms and closes again. But this emphasizes the importance of taking care of acid reflux early on. There's other problems that can happen. You can have severe inflammation or ulcers or erosions, and they can bleed. Also, one very important problem that we always like to talk about is Barrett's esophagus. And in case of Barrett's esophagus, and as I said here, this is a description of how the acid in the stomach can find its way up and cause inflammation and ulceration in the esophagus. And the important thing here is that and I do have, I believe, a slide for Barrett's. Well, sorry, it's not here, but suffice to say, when acid goes up and irritates, this lining at the bottom here ends up developing a new lining. Irritation over the years, again and again, causes the lining to change into a new lining. This new lining we call Barrett's esophagus. It has a risk of developing cancer in it, 1 in 200. It's not very high, which means that it's less than 1%, it's actually 0.5%. But we do see it. It's not just a small number, it exists. Now I have a long list of patients with Barrett's that I follow. We keep an eye on patients with Barrett's closely. So we do endoscopy every 2 to 3 years to make sure that no changes in the lining happens without us knowing about it. We take biopsies, and at the moment we see any change in the lining or in the cells, we immediately jump on it and treat it to make sure that the Barrett's esophagus doesn't progress into cancer. Now I have to tell you, I just today scoped somebody who had Barrett's that did not show up for any follow-up and did have cancer developing in it, and it was a little advanced. So the important thing about acid reflux, and I guess this is what I'm trying to relay, is that cancer is really progressing significantly. The incidence of cancer of the esophagus is increasing. It's almost increased by 6-fold. There's hardly a month that passes without me diagnosing 1 or 2 esophageal cancer. And it's even higher now, faster than the rate of increase in the breast cancer, prostate cancer, or even skin cancer. So it's very important that we pay attention to our acid reflux and really get it treated and investigated as well. The important thing about acid reflux is that its management is actually easy. But before we get to the management, how do we go about investigating somebody with acid reflux? Of course, the golden standard is doing an upper endoscopy. We put you to sleep. We take the camera to the mouth, into the esophagus and the stomach. We look at the esophagus carefully. We look at the area where Barrett's can develop. If we suspect it, we take biopsies from that area, and we usually, put you on treatment there and then. There are other ways by X-ray, but X-ray does not really diagnose Barrett's. There's no way it will be able to see the tissue or be able to take biopsies of it. So it's definitely more inferior than EGD. If there's any suspicion whether you have reflux or not, like somebody comes in with chest pain, now we're not sure if this is acid reflux. If I go in and take a look and your esophagus looks completely normal, that does not mean that you don't have reflux. You could be having reflux but didn't develop the inflammation in the esophagus yet. So there is a way that we can do it, which is called a Bravo pH testing. This is a small capsule. I don't have the picture of it. But this capsule, we go in with the camera, with the scope, and we attach it to the lining of the esophagus close to the bottom. And it usually attaches there for 2 days and then falls off and disappears. But during those 2 days, we will give you a beeper, a small receiver, that will collect all the information the capsule is reading. What the capsule will read is how much acid is coming up into the esophagus. And it continues reading for 48 hours. So we have a 48-hour stretch of a period where we can see what's happening in your esophagus all the time. This helps us. If you have chest pain and you have a button usually to press on that beeper, if you get a chest pain, you press on the button, it puts a mark. If at the same time I see the acid is increasing in your esophagus at that time, then I can correlate the two. I can say when she presses on the button with the chest pain, she is having at the same time a lot of acidity coming up to the esophagus. So yes, the answer is the chest pain is caused by acid reflux. So we can correlate what you feel with what's happening with your esophagus. So how do we treat it? The common scenario usually starts always with behavior changes and lifestyle changes, and that means several things. The number one thing, of course, I always tell my patients, the two things that we usually like to highlight to my patients. I tell them three. I know there's a whole bunch, but I like them to remember, and so maybe when you make them into 1, 2, 3, it becomes a little easier. Number one, always I tell them don't eat in the last 3 hours before you go to sleep. This has been definitely proven to help acid reflux significantly. In the proximity of the time when you go to sleep, count backwards and say this period of time is protected, no more food, no more drink, except maybe water. Number two that has been proven by studies to help is elevating the head of the bed. And by that I don't mean a couple of pillows under your head, because that will only raise your head. We need your chest to be slanted up. And so the best way is to put something under the head of the mattress itself. So you can fold a couple of blankets or put a couple of pillows or a couple of phone books, and that will give you this inclination that prevents reflux happening at night. And this very much helps people with acid reflux who have nighttime acid reflux. The third thing is foods. Certain foods are well known, and drinks to help to make the acid reflux worse. Especially spicy food, and we're here in the South, so every time I tell a patient you have to cut down spicy food, people are like, oh, what are you telling me, doctor? I can't eat spicy food, we're here in the South. So I tell them, you will probably know by now that when you eat this, you get this. So most of the time, you know when you look at the food, if you had heartburn for a long time, you know this is going to be bad for me today. So the best thing really is to try to get as less spicy food as possible. And if you want to have it, but don't make it as a main meal. Have it as a small side dish, and don't have it in the evening, closer to the time when you're going to go to sleep. So take it infrequently, in small amounts, and earlier in the day. That's what I tell my patients. Other than spicy food, red tomato sauce. Tomato sauce causes this. The V8 in tomato juice usually causes a lot of heartburn. People who eat foods with tomato paste like pizza, usually they know that they get heartburn after pizza. The juices, they all have acid in them. They're all citruses, and they all have citric acid. Orange juice, lemonade, pineapple, cranberry, and apple juice. And many people are in the habit of drinking these before they go to sleep sometimes, and they get a lot of heartburn because of that. Caffeine, such as coffee, tea, and soda, also stimulates a lot of acid reflux. Now people say, so how about decaffeinated beverage, I tell them decaffeinated is not zero caffeine. If you end up drinking too much, you still have a good amount of caffeine. So these are the 3 things that I tell them about. Don't eat or drink in the last 3 hours before you go to sleep. Elevate the head of the bed and watch for these, cut down at least for these drinks and foods. Now, of course, if they gained weight, I tell them lose the weight. If they're smoking, I advise them to stop smoking. But that's always the first step that helps taking care of the. Alone, I find it not sufficient. You have to add some medication with that. And I prefer usually the PPI or the medications that we have. Let me go back again for a second. So what we have is several medications over the counter. We always, for many years, had Zantac and Pepsid. So we have those for tens of years. They've done good, but they're not excellent. They still lack a lot in terms of strength. So alone, they're not really sufficient in controlling reflux. We had the better medications came maybe 15, 20 years ago with Prilosec and then Prevacid and Nexium and Protonix and Zegrid and Acifix and others, and Dexilent as well. These are a group of medications that we like more. They are far much more effective. What they do is that they actually prevent the production of acid from the stomach. And that's what you want. You want to cut down on the acid secretion from the stomach. That's how you control the reflux better. And it's okay to be on them for a long period of time, but with the recommendation of your doctor. So if you pick it over the counter, don't take it forever. Take it for 2 or 3 weeks until you see the doctor. But when you see the doctor, he will tell you if it's okay to continue taking them or not. And most of the time, we recommend them, especially if you have chronic acid reflux and you have strong symptoms. Now, there are some also discussions every now and then about surgery. Now, commonly we like to reserve surgery in certain specific situations, especially if you have a big hiatal hernia. Now, what a hiatal hernia is, and I want to explain it because it's related to reflux, is a little weakness in the diaphragm that allows part of the stomach to slide up into the chest. That's a hiatal hernia. The diaphragm is a very big muscle that cuts us into 2 halves between the chest and the abdomen. It's a very big muscle, and it has a small opening through which the esophagus goes and connects with the stomach at the bottom. So the esophagus is above, the stomach is below. This opening is a muscle. It should be tight. If it becomes loose, then it allows the stomach to slightly slide up into the chest. If it's small, we don't do anything for that. But if it's large, then we may recommend doing surgery for that. And the surgeon wraps the stomach, pulls it down back in the right place, and wraps it and closes that big area into a small area again. So we reserve surgery for acid reflux in very specific situations, but it's not usually commonly advised for everybody. So in general, acid reflux is a very common disease. It has a lot of symptoms. We need to pay attention to other symptoms other than just heartburn. It's also some of these symptoms can be very significant. We have to keep an eye on them. If you're losing weight, if you're having problems swallowing, and if you're having chest pain, it's very important that you see a doctor about this acid reflux. Controlling it is very important to prevent the complications like stricture, Barrett's esophagus, and cancer. But the most important thing is that you have to consult with your doctor to be on the right treatment, and we have to investigate you to find out more about it and let you know more about it. Screening colonoscopy is very important. I don't think that we usually, as gastroenterologists, like to skip any opportunity for telling you that it's very important to identify this silent killer. Colon cancer usually produces no symptoms at all until it's a little too late. And that's why everybody above the age of 50 have to have a colonoscopy every number of years. The number of years would depend on whether you have polyps, whether you have family history of colon cancer or not. At this time, happy to answer any questions, and it doesn't have to be about acid reflux. If you have any question regarding the GI, liver, or pancreas, I'll be happy to answer it.